Good morning, dear students. Today's lecture's topic is features of complaints, medical history, objective, laboratory, and instrumental investigations of patients with syndromes in respiratory systems pathology. Plan of current lecture, we intend to discuss clinical part, complaints, medical history, results of objective examination of patients with syndromes in respiratory systems pathology. We intend to describe instrumental and laboratory investigations. Main complaints of patients with diseases of respiratory system, these are cough, sputum, productive cough with sputum, dyspnea, can be asthma attacks, suffocation attacks, chest pain, and hemoptysis. The most frequent symptom is the cough. This is a reflex which protects in response to accumulation of sputum, mucus, or foreign bodies in the airways. And during objective exam, during gathering patients' complaints and anamnesis, we usually clarify some questions, characteristics of cough, triggering factors, duration of cough, time of appearance of the cough, and relieving factors. Clinical meanings, there are different meanings of clinical meanings of different types of cough. For example, dry cough. Dry cough means the cough without sputum. It can be in laryngitis, in dry pleurisy, pleuritis, in pneumosclerosis, in bronchial compression. On the other hand, as we stratify second type of cough, this is wet cough or productive. In clinical setting, we usually use definition productive cough. Productive cough can be found in many diseases of respiratory system. About dry cough can be result of can be found in respiratory system diseases and non-respiratory system disease. For example, GIT system disease, gastroesophageal reflux disease. It can be found in patients with gastroesophageal reflux disease. They can complain for dry cough. As for other diseases, asthma is typical disease which is accompanied with dry cough. But in asthma, the patients they usually suffer from dry cough and acute suffocation as a response of contact with allergy in patients with atopic asthma. Dry cough can be found in patients with nerve sensitivity. It can be a side effect of some pharmacotherapies, medications. For example, the most typical side effect of AC inhibitors, dry cough. And dry cough can be also in patients with heart failure, but in patients with heart failure, we usually find out on other symptoms of heart failure, like such as breathlessness, fatigue, and in patients with heart failure, especially in patients with congestion of blood in pulmonary circulation, we usually find out patients they usually complain of the cough, which is related with horizontal position. Also, lung cancer patients with lung cancer can complain of dry cough. About productive cough, there are different kinds of sputum type. Can be mucus sputum, can be purulent sputum, or other kinds of sputum. But most of patients with wet cough, they are related with some infection for example, bronchitis or pneumonia. And we usually find out symptoms of productive cough in patients with chronic obstructive pulmonary disease, the COPD. This disease is the main symptom, leading symptom of the COPD is the productive cough, prolongated productive cough. And we highlight patients with COPD as this group of patients. They are very prevalent among among pulmonological patients. Bronchiectasis also is usually manifested by productive cough, but they have purulent type of sputum. And other diseases, non-tuberculosis mycobacteria infections. This is a non-contagious cousin of tuberculosis, and it can be accompanied by fatigue, weight loss, and feeling of being generally unwell. About duration of cough, we notice persistent cough. Persistent cough is usually typical for patients with tuberculosis, bronchogenic cancer, and chronic diseases. I have just told you about COPD. They have long prolongated cough. Can be we stratify also silent cough. Silent cough can be observed in the vocal cords if the vocal cords are affected. And next subgroup of cough, this is periodic cough. At periodic cough, there is exacerbation of, it can be in patients with exacerbation of chronic bronchitis, bronchiectasis, or bronchial asthma. In patients with bronchial asthma, we notice paroxysm character of cough. Next symptom, this is sputum. In the presence of sputum, we should clarify first amount of sputum per 24 hours. Second, consistency, liquid, viscous, thick, or glassy. Next characteristic, color. It can be gray-green, light, rusty in patients with pneumonia or presence of blood. Spitting, sputum, it is difficult or easily presence of smell, and layering when standing. This table is presenting different types of different colors of the sputum and appropriate diseases. For instance, in patients with allergic rhinitis, we usually find clear sputum. In bronchitis, it can be different colors from green or yellow, or brown, white, up to clear. In patients with COPD, it's usually white. In congestive heart failure, white or red or pink due to permeability of red blood cells, etc. So that's why we can suspect appropriate etiology of appropriate disease, taking in account the color of the sputum. Next symptom, typical symptom is frequent symptom. This is dyspnea. Dyspnea means the difficulty of breathing with changing of frequency, respiration depth, and rhythm, and feeling of shortage of air, shortage of breath. And shortness of breath is a change in the frequency of breathing, depth, and rhythm of breathing. By the way, we take into account the breathing rates. The breathing rate normally it's about from 16 up to 20 per minute at rest time. But patients with dyspnea, they usually have more frequent breathing rate. On the other hand, dyspnea, this is a subjective symptom. That's why the measurement of frequency of breathing rate is can help the doctor in diagnostic process. Dyspnea. This slide is demonstrating the main principles of breathing. The breathing has two phases: phase of inhalation and phase of exhalation. During asking patients survey, we try to clarify the severeness of breathlessness. We clarify which period of breathlessness occurs. Breathlessness at both phases of breathing, during inhalation and during exhalation, is called as mixed dyspnea. Patients with difficulties during inhalation, we use definition inspiratory dyspnea. Patients who are having difficulties of breathing during exhalation, we use the definition expiratory dyspnea. Inspiratory dyspnea, it can be in patients with mechanical obstruction or in the upper respiratory tract, or restrictive disorders, for instance, neuromuscular diseases, kyphoscoliosis. Patients with mixed dyspnea, they have difficulties breathing during both phases of breathing, during exhalation and inhalation. And mixed dyspnea can be observed with a decrease in the respiratory surface of the lungs. For instance, syndromes of hydropneumothorax, inflammatory consolidation of the lung tissue, obstructive atelectasis, acute left ventricular failure. Patients they can complain of different types of dyspnea according the onset of this symptom. For instance, first type of dyspnea, intermittent or temporary dyspnea, which occurs during exercise, physical exertion. And second type of dyspnea, constant dyspnea, it occurs during exercise and at rest, and which characterizes the severity of respiratory failure in patients. Next symptom, this is asphyxia. Asphyxia is this is a very fast, sometimes suddenly developing dyspnea accompanied by acute lack of air. And asphyxia might be also predominantly inspiratory, expiratory, or mixed form of asphyxia. Expiratory asphyxia attack is usually typical symptom of patients with asthma. Next symptom, this is chest pain. Chest pain is usually a symptom of patients with pleuritis, dry pleuritis due to lesion of pleura. It can be in patients with lung diseases involvement in the pathological process of the pleura. For instance, lobar pneumonia, lung tumor, pulmonary infarction in patients with thromboembolia of pulmonary artery, Also, chest pain can be found in patients with pneumothorax. They feel intense pleural pain. And pathology of the intercostal nerves and muscles. These are vast majority of patients with myositis, intercostal neuralgia, contusions, and fractures of the chest bones. Chest pain in patients with pleuritis, we clarify some characteristics of chest pain: localization, irradiation, intensity, and duration. In pleurisity, the pain is usually acute, intense. This pain is localized on the site of the lesion and sharply intensified when during breathing, coughing, bending to the diseased side, and decreases when lying on the patient's side. Next symptom, this is hemoptysis. What does it mean, hemoptysis? This is presence of blood in sputum. The patients, they discharge blood with sputum during coughing. Can be disease. We stratify hemoptysis to different types. First type, scarlet or fresh or modified blood. So blood in the sputum in the form of veins is observed during destructive processes, bronchiectasis. Next type of hemoptysis, rusty sputum, is observed in patients with pneumococcal pneumonia. We also stratify different types of hemoptysis. For instance, viscous sputum type, like raspberry jelly, it's typical for patients with lung cancer. Purulent bloody blood with a putrid odor, with absence or with abscess or gangrene of the lung. Next type, pink frothy sputum, appears with the development of pulmonary edema in patients, for instance, in patients with mitral valvular heart disease or acute myocardial infarction with rupture of papillary muscles. And sometimes pulmonary hemorrhage can occur with a decaying tumor from a tubercular cavern. We clarify some characteristics of hemoptysis. First, we find out cause of hemoptysis. We assess amount of blood, and we ask the nature of blood. As for scarlet hemoptysis, fresh or modified blood in the sputum in the form of veins, we suspect bronchiectasis. Rusty sputum, we must rule out or confirm pneumococcal pneumonia. Raspberry viscous sputum type, like raspberry gel, we usually suspect lung cancer. Purulent bloody brown with a putrid odor, abscess or gangrene of lung. Pink frothy sputum, we must rule out the pulmonary edema and other diseases. During objective examination, we perform inspection, palpation, percussion, auscultation. Inspection, we assess the general condition of patients, satisfactory or moderate condition or severe condition. We assess consciousness, position of patient's body, active, passive, or forced position. In an attack of suffocation, the patients usually they sit and resting on the edge of the bed or chair, therefore fixing the muscles of the upper shoulder girdle. Due to this, the respiratory muscles, which improve the exhalation, include the breathing process. So we use a simple definition, orthopnea position. They try to use this orthopnea position. And the next typical position of patients with dry pleurisity, patients, they usually lie on the patient's side. And it helps to reduce, diminish pain in connection with restriction of friction of the leaves, pleural leaves. Inspection is usually means carefully inspection of patient's skin. Skin color can be cyanotic. This is a sign of insufficient blood saturation with oxygen in case of respiratory failure. For instance, look at this photo. We can see cyanotic color of hands and especially fingertips. This is patients with respiratory failure, but the same color, or you can find out in patients with heart failure. The main difference between them, this is the temperature of skin. It's easy to differentiate. You touch your patient's fingers, patient's skin, and patients with respiratory failure, they usually have warm skin, unlike patients with heart failure. So in chronic purulent disease of lungs, bronchiectasis, for instance, abscess, in chronic abscesses, it is possible to identify a thickening of peripheral phalanges, or you can see it this. This is symptom of drumstick, and also you can observe appropriate changes of shape of the nails. Chest examination, we assess the angle of epigastric angle. Next, we assess we perform other instrumental tests. We assess oxygen saturation, for instance, and blood gases. Respiration, breathing. So this slide is demonstrating the expiration and inspiration. During objective examination, we notice the general shape of chest, and in order to differentiate normoasthenic, asthenic, or hypersthenic or pathological shape of chest, we notice the symmetricity of the chest shape of the chest, and we assess the epigastric angle. Patients with normoasthenic angle, they usually have approximately 90 degrees of this angle. Asthenic, they have narrow angle. Hypersthenic, they have wide angle. Also, we notice the symmetricity of breathing. Intercostal, we assess intercostal spaces, and we calculate the respiration rate, and we assess the depth of the rate, or depth of respiration, and we take into account the participation of auxiliary respiratory muscles in the act of breathing. It's typical for patients with respiratory diseases. And we take into account the type of respiration. This slide is showing different shapes of the chest. This is normal chest, can be pectus excavatum, funnel chest. This is congenital disorder, pectus carinatum. It can be also as a congenitum or as a result of rachitis in the childhood. And we focus our attention at the barrel chest. Barrel chest is a typical deformation of chest in patients with pulmonary diseases. Especially it is typical for patients with COPD, at end stage of bronchial asthma. What is the characteristic of barrel chest? We assess the distance between the vertebra and sternum, and unlike normal chest, patients with barrel chest, they have enlarged distance between the sternum and vertebral. Other types of the chest deformations, pectus excavatum, funnel paralytic chest, hypersthenic chest. Hypersthenic chest, you can observe widened epigastric angle. Next step is palpation of chest. There are several reasons for performing palpation of chest, because we can find out the painful areas of the chest. It is necessary for clarification of nature of pathological changes revealed during objective examination. It is necessary for further evaluation of chest respiratory excursion. We can assess resistance of chest and intercostal spaces. For instance, patients with hydrothorax, emphysema, or ossification of costal cartilage. And we assess the voice jitter. Palpation of chest, how to perform, you can see at these images. We assess the voice jitter, and different changes of voice jitter can help to clarify diagnosis. Next is about palpation. This images showing the palpation of chest. Definition of voice jitter or voice quake. We can find out weakening of or strengthening of voice jitter. Weakening of voice jitter is typical symptom for patients with increased subcutaneous adipose deposits in patients with obesity, in the presence of liquid or gas in the pleural cavity, in the presence of pleural adhesion and mooring, obstructive atelectasis syndrome, bronchial obstruction syndrome. As for strengthening of voice jitter, due to improved voice performance, and is encountered in case of thin chest in patients with cachexia, in patients with lung tissue induction syndrome, the presence of a cavity communicating with the bronchus, and compression atelectasis syndrome in the area of lung tissue consolidation. This slide is demonstrating palpation of chest, definition of voice jitter, step by step how to perform this procedure. Next, percussion of thorax. There are different types of sound obtained during percussion. Clear pulmonary sound, blunt femoral sound, tympanic, blunt tympanic, and box sound. Also, we perform two approaches for percussion. First approach, comparative percussion, and second, topographic percussion. And both of them, they have different objectives. We use percussion in order to assess the lower inferior lung border. This image is demonstrating the procedure methods of assessment of lower lung borders. And percussion sound can be changed, and this changed percussion sound is typical in different pathological conditions. For instance, the dullness of percussion sound is determined by reducing the airness of the lung tissue and the appearance of dense areas. It is very typical for patients with pneumonia, pneumosclerosis, lung tumor, and in case of presence of pleural adhesion and mooring. As for dull sound is observed usually with pneumococcal pneumonia, hydrothorax syndrome, obstructive atelectasis syndrome, in the presence of a tumor of considerable size with a pronounced thickening of the pleural sheaths, and the development of a powerful adhesions process with lung abscess or tuberculosis of the cavity before emptying. Blunt tympanic tone is usually typical in patients with pneumosclerosis, lobar pneumonia in stage 1 and 3, compression of atelectasis, pulmonary edema. As for the tympanic sound is usually found in patients with tuberculosis cavity in the presence of cavity communicating with the bronchus, in patients with lung abscesses, in the emptying stage and large bronchiectasis, and in the presence of a large smooth-walled cavity located superficially, the tympanic sound can be as a metallic shade. Box sound is typical for patients with increased airness of the lungs. This is usually patients with emphysema. And limitation and reduction of mobility of the lower edge of the lungs is typical for patients with high standing of diaphragm. These are patients with ascites, meteorism, pregnancy, emphysema, pneumonia, and hydrothorax syndrome in the presence of adhesions in the pleural cavity, bronchial obstruction syndrome. The causes of change in the boundaries of the lungs, we stratify to different types. First, increase upper and lower bounds. This is typical for pulmonary emphysema, asthma attacks. Second type, decreased upper lung margin in patients with obturative atelectasis. Next type, increased upper bound in patients with comprehensive atelectasis. And next is decrease of lower bounds in the presence of fluid or air in the pleural cavity and hypertrophic asthma attack. Auscultation is a very valuable approach. We use a stethoscope, we use warm environment and calm environment. Patient is breathing, and we assess signs, we assess sounds. And there are different types of the breathing. Normal respiratory sound, when we can listen to full inspiration and 1/3 of expiration. And patients with bronchial respiratory sounds, we can listen to full inspiration and full expiration. Pathological bronchial respiration occurs when lung tissue compaction, compression atelectasis syndrome. About amphora breathing. Amphora breathing is usually typical when air moves through the cavities. It's typical for patients with lung abscesses or with cavity syndrome communicating with the bronchi. And next type of breathing, strengthening vesical respiration, increase inspiration and expiration without changing the ratio with thin chest, and hyperventilation that develops on the part of the lungs that is opposite to the pathological process. Next symptoms, this is crepitus. Crepitus is a sound that occurs when a large number of alveoli collapse during inhalation, when there is a small secret in them, and listen to at the height of breath. And next is pleural friction sound. Pleural friction sound occurs as a result of raw pleural leaves friction against each other when there is no exudate in the pleural cavity. It is typical in patients with dry pleuritis. Instrumental and laboratory research methods. We refer patients' sputum specimen to sputum lab tests, and there are different types of sputum tests: general sputum test, culture test, or gram stain test. During general sputum test, we perform macroscopic and microscopic assessment. At macroscopic assessment, we assess character of sputum, color, consistency, smell, and reaction of sputum. As for microscopical assessment, we evaluate elastic fibers. Sometimes we can find out chocolate crystals, actinomycetes, candida, malignant tumor cells, Mycobacterium tuberculosis. So that's why the both macro and microscopic assessment, they are useful and helpful for investigation. For microscopic investigation, we usually find out squamous epithelium. This squamous epithelium, it doesn't have diagnostic value. As for cylindrical ciliated epithelium, it is present in small quantities in any sputum. In large quantity, it can be symptom of lesions of the respiratory tract, as for example, bronchitis, bronchial asthma. Next symptom, alveolar macrophages, they are found in small quantities in any sputum, and their content increases in inflammatory diseases. Instrumental investigations, we use very few patients to different instrumental tests, for instance, X-ray examination, chest X-ray, radiography, tomography, bronchography, at other. And all above mentioned investigations, some of them they use X-ray exposure, some of them they are lack of X-ray, free of X-ray exposure. These images are plain chest X-ray of patient. The left, the picture A, photo A, this is the frontal. The photo B, this is lateral projections. And we assess the intercostal spaces, we assess the position of ribs, we evaluate the costophrenic angles, we evaluate the signs of emphysema at this end. Also, we assess the position and shape of diaphragm. For example, for instance, here we can see flattened diaphragm and wide intercostal spaces. Next instrumental test, this is peak flowmetry. Peak flowmeter means determination of maximal expiratory flow rate. We use small, simple equipment, peak flowmeter. Peak flowmeter, this is a portative device. It is usually recommended for patients with obstructive syndrome as their individual device. Peak flowmetry decreasing maximal expiratory flow rate less than 80%. It is considered as a sign of evidence of obstruction. Next instrumental tests, CT, computer tomography assessment, and bronchography. CT scan is useful for assessment of changings of the lung parenchyma and pleura and bronchi. And CT is a very valuable instrumental test for some patients, for example, for patients with bronchiectasis, with tumors, because CT scan provides more accurate imaging than chest X-ray. Next method is bronchography. Bronchography is not routine test, but bronchography can be useful for assessment of bronchial tree and combination of bronchography with angiography of pulmonary artery branch. So it is the gold standard for assessment of thromboembolia of pulmonary artery. The next method of investigation, this is spirometry. Spirometry, this is functional test. It can evaluate the function of lung. Obstruction spirometry is necessary for confirming diagnosis of obstructive diseases, for instance, bronchial asthma or COPD. And during spirometry, patients is performing deep inspiration, expiration, forced expiration, etc. And spirometry can be performed at initial without medications, and spirometry can be repeated after taking short-acting bronchodilators. And this slide is demonstrating different lung volumes in normal and in diseases in different conditions. So the next method of investigation, this is pleural puncture. Pleural puncture is used to determine the nature of the pleural fluid in order to clarify the diagnosis as well as to remove fluid from the pleural cavity. Pleural cavity puncture is performed under the local anesthesia, and pleural puncture can be performed as a in a two objectives, as I told you. First objective, diagnostic. Second, diagnostic plus treatment in order to improve patient's condition. Next method of investigation, this is thoracoscopy. Thoracoscopy, this is invasive procedure. We perform special equipment in order to assess morphological changes of pleural layers, pleural cavity. And at this image, you can see that the thoracoscopy, medical thoracoscopy is performed in the Department of Pulmonology. Next method of investigation, this is fibrobronchoscopy. Fibrobronchoscopy is of limited value in patients with pleural effusion of unknown etiology. Fibrobronchoscopy is indicated in the presence of radiological signs of neoplasm and decrease in lung volume in patients with history of hemoptysis, even the possible aspiration of a foreign body is performed. The fibrobronchoscopy is performed under the local anesthesia, and it is usually performed at the outpatient hospitals. Let's make conclusion, take-home messages. The basic skills of techniques of clinical physical examination of patients with respiratory syndromes are useful for medical practice, and doctors must know clinical syndromes in the most common diseases of the respiratory system. And next conclusion, methods of laboratory and instrumental examination of patients with respiratory syndromes and interpretation of results can facilitate correct diagnosis of patients. Thank you for attention. We have finished our lecture.